exciting edition of Young Guns webinar. And today we have the Young Guns from Karnataka chapter of SFM who will be presenting their exciting cases. And I'm really honored to be a part of this Young Gun program, which was envisaged by Professor Ashok Khurana, and the mandate was given by uh, Mohit Shah sir that we need to give opportunities to young presenters of every chapter. And I'm really glad that this program has it has taken up. And every month we do these webinar in which the young presenters they present. And I think, as time has progressed, everybody is very keen, very excited to present their cases, showcase their work on this platform that SFM provides. So I would request Dr. Adi Narayan Makam to say a few words about the young guns of their chapter. Adi sir, over to you. Adi sir, please unmute yourself first.
Yeah. Okay. Sorry. Good evening once again. Alok sir, Ashok Khurana sir, Bimal sir, Mohit sir, and all the seniors and my colleagues. It's a fantastic opportunity created and originated by, I think the Varun has given an idea, and then Alok sir and Ashok sir made it a big thing, and fantastic opportunity for all young, budding, and enthusiastic fetal medicine specialists can present their work. And this is a wonderful platform. Uh, thank God Ashok Khurana sir is there to bless all of us and bring them all together. And today, in the last months, West Bengal program was fantastic. I was totally mind blown. And this time also, we have wonderful six young guns prepared their cases, and they were being mentored and trained, and they rehearsed their presentation, and they are on dot for 10 minutes. They're going to finish, and then this is a test of their talent as well. I thank Murli and Alok for training them and mentoring them. So without wasting much time, we could start the program and we'll have fun. And before I stop, I request all of you to, those who have not been members, I request all of you to become members because there is fantastic facilities, opportunities, and get together. I don't want any of you to miss. And please make sure that if you're not registered for SFM, be a member today. Thank you.
Thank you, Adi sir. And now I hand over the program to Dr. Murlidhar Kamlapurkar, who is a secretary of SFM Karnataka chapter, and he is the master of ceremony of today. And all these young presenters, they have been, mentored more by him rather than me. He is the one person who's handpicked them. And over to you, Murli.
Good evening, Alok sir. At outset, I would like to thank Purana sir for being here for this occasion. I'm extremely lucky. Then I also thank Bimal sir for being there on the function for the event. Then Adi sir. Then I'm also grateful to Mohit sir for I keep troubling him every now and then for all the guidance. So this is an excellent opportunity to provide an opportunity to our young people who want to present their work. So without much delay, I would request the first speaker, Dr. Sana, to begin her presentation. She'll be talking on AP window. Dr. Sana is a fetal medicine fellow at Adi Advanced Center for Fetal Medicine at Bangalore. She'll be talking on an interesting scenario called Aortopulmonary window.
Oh, yo.
Mohit sir.
Mohit sir has joined.
Sorry, I could
welcome
not.
Mohit sir, our national president of SFM.
No, I'm so sorry I could not unmute. Welcome all, and I'm really looking forward. I agree with Adi. This is a fantastic concept taken ahead well by Varun and Alok. It's a fantastic opportunity for youngsters. But more than that, it is immensely satisfying to see such young talent presenting such wonderful cases when well worked up cases. It's a good platform for youngsters and a good learning sessions for every practitioner who's interested in fetal medicine. Looking forward to it. Please continue, Dr. Murli.
Yes, sir. Thank you, sir. Dr. Sana, she'll be giving a first talk on aortopulmonary window.
Yes, sir. Should I share screen, sir?
Yeah, share the screen. Dr. Sana is currently pursuing her fellowship at Adi Advanced Center for Fetal Medicine at Bangalore.
Sir, can you see the screen, sir?
I think it's being shared. Yeah, I can see. Yeah.
Yes, sir. Good evening, everyone. I'm Dr. Sana Verma, current fellow with the Dr. Adi Narayan sir, and today I'll be talking a little bit about the aortopulmonary window. So directly, I'll show you my first case, which was a 27-year-old. She had come to us at 22 weeks, 6 days, gravida 3, para 1, with 1 early pregnancy loss, and previous baby was healthy. She had come for second opinion for right-sided aortic arch. So when we started the scan, we saw that on 4 chamber, the heart looked completely normal. But going up to the 3 vessel and the 3 vessel trachea view, we could see that there was a defect between the aorta and the pulmonary artery, which is the AP window. So on extending examination, when we put color, we saw that there was color flow through this defect. And we could see that there was a continuous flow between the aorta and the pulmonary. So this was the pulmonary artery, this is the aorta, and this was the defect, which is the AP window. And here we can see color also flow through the AP window. So on a little bit higher section, we see that the aorta is actually right-sided, and this is right, this is below is left. So the aorta was right-sided, and we also see a vessel crossing over behind the aorta. So this is the SVC, and the vessel is draining into the SVC, and we see a little bit of color here. So this was actually the retroaortic left brachiocephalic vein, which is, this is the aorta, and this is the retroaortic left brachiocephalic vein draining into the SVC. So on 3D, when we start from the on-fast AV walls view, going up a little bit, we can see that this is the LVOT arching, and we can see the valve also. And then when I rotate, we can see the RVOT. This was the right ventricle outflow tract. And again, we can see the valve. And as we walk through, we see actually that there is a connection between the aorta and the pulmonary. So this was the AP window. And this was an image showing the single aortic arch with the head and neck vessels, and there's no ductal arch. So this was a right-sided aortic arch with an absent ductus arteriosus. So again, we can see actually on this surface rendering, this is the aorta going behind the pulmonary trunk, and this was the pulmonary, and this is the defect, which is the AP window, aortopulmonary window. So just to reiterate, 4 chamber was completely normal. This is below is the pulmonary, above is the aorta, and we can see the defect between the two. This is the AP window. And then going further, we can see the 2 separate walls, which is very important because truncus is a common differential diagnosis for a large AP window cases. And we can see the flow through the AP window between joining the aorta and the pulmonary trunk. And here as well, we can see the continuous flow, and a little bit higher up, we can also see the right-sided aortic arch with the SVC and the retroaortic left brachiocephalic vein. So this patient was actually counseled for postnatal management and about the possibility of operation, but she did not want to take any risk, and she opted for termination of pregnancy. We got the fetus for autopsy. We saw the right-sided aortic arch, and here we are actually trying to see the retroaortic left brachiocephalic vein. Unfortunately, tissues were a little bit friable, so we have gone through one of the branches of the aorta, but behind that, we can see that thin vessel that is there, that is the retroaortic left brachiocephalic vein. So this is the retroaortic left brachiocephalic vein crossing over behind the aorta. And when we are looking posterolaterally from the left ventricle, we see that this is the AP window. So looking at the autopsy images, this is the sinus of Valsalva in green. And this in red, which I've circled, is actually the left coronary artery ostium. And this big one, that is the AP window. So again, we can see that this defect, the AP window, is actually a little bit further away from the sinus of Valsalva. So this was a type 2 defect. This was the report that we had given to our patient. And we had said right-sided aortic arch with absent ductus arteriosus, a type 2 aortopulmonary window, and retroaortic course of the left brachiocephalic vein, and an AIF as well. So the classification given to us by Mori, which was the original classification, it classified AP window into 3 types. First, type 1 is the proximal defect, in which the defect is located just above the sinus of Valsalva. Type 2 is a little bit distal defect, in which the connection is between the ascending aorta up to the origin of the right pulmonary artery. And type 3 is a mode is involving the entire length of the pulmonary trunk, where the origin of the right pulmonary artery is from the aorta as well. A newer classification by Ho et al. Has been added, in which they have said type D, which is intermediate defect, involving any part of the aorta and the pulmonary trunk. So I'll touch upon embryology just a little bit so that we can see how the AP septum actually develops. So this is the primitive heart tube with the arterial and the venous end. And we know that the bulbous cordis has 3 parts: the proximal 1/3, the middle 1/3, which is the conus cordis, and the distal 1/3, which is the truncus arteriosus. The aorticopulmonary septum is derived from the conus cordis and the truncus arteriosus. And during development, the conus cordis and the truncus arteriosus, they develop swellings which are known as ridges, and these are derived from the neural crest cells. These ridges, known as truncal and bulbar ridges, actually grow towards each other, and then they fuse to form a spiral course for the great arteries. So upon, if we look from above at any given level, this is how we see the septum developing. And upon fusing these ridges from the conus cordis, form the smooth outflow tracts, that is the infundibulum on the right side and the aortic vestibule on the left side. And the ridges from the truncus arteriosus form the aorta and the pulmonary trunks. So they can eventually cross over and lie like this. So coming to the treatment and complications of AP window, if left untreated, these babies can develop congestive heart failure and pulmonary hypertension because of the left to right shunt, with irreversible pulmonary vascular diseases, the Eisenmenger syndrome, and small AP windows may just have murmurs. They do very well post operative, if especially if they are intervened, if the intervention is done early on, and usually a dacron or an autologous pericardial patch repair is done. And these babies actually post operatively, very few of them have any residual pulmonary hypertension. AP windows are associated with arch abnormalities, Vactrals, triploidy, trisomy 18, 13, and X-linked myotubular myopathies. But what is very interesting is that even though it is a conotruncal abnormality, there is no reported incidence of association with the 22q11 deletion. So my second case is a companion case to the first one. This was a 32-year-old lady. She had come to us at 23 weeks, 3 days, gravida 2, para 1, previous baby is healthy, and second opinion for coarctation of aorta. So again, when we looked at the 4-chamber, it looked completely normal, but we had the suspicion of a small defect between the pulmonary and the aorta. So of course, we wanted to examine further. And when we looked at the parasternal long axis view, here also we could see that there was the possibility of a defect, and at a better insonation on the 3-vessel view also, we saw that there was a AP window between the aorta and the pulmonary artery. So on color examination as well, we saw that there was flow between the aorta and the pulmonary. And actually, if we see here, this is the origin of the right pulmonary artery, and this is the defect, which is the AP window. So it is just proximal to the origin of the right pulmonary. There was associate coarctation of the aorta, and we can see some focal narrowing here, and the duct isthmus ratio was about 0.7. And on color examination, we got the pathognomic turbulence in the pulmonary artery with the red eye sign. Here is the small red eye we are seeing in the pulmonary artery. So this was a paper by the Israel group in which they have retrospectively examined about 10 cases of AP window, and in all cases they have been able to see the red eye, which they have described as the presence of a vascular fistula between the pulmonary artery and the aorta, and causing reversal or turbulence in the pulmonary artery. So unfortunately, my second patient, this patient was kind of lost to follow up. We had counseled the patient appropriately, told them about the possibility of all postnatal management and follow up, even maybe the need for postnatal operation. And the patient decided to continue pregnancy. She delivered a baby boy, but I only managed to have a single telephonic conversation with them in which they informed me that follow up with a leading pediatric cardiologist center here in South India has been done. And the parents had been told that the baby could be managed conservatively. The baby was already 3 months old and was apparently doing well without any significant morbidity. So even in this paper itself, actually, they have had two cases in which which have had a very good prognosis, where one patient had an AP window which was diagnosed at 14 weeks and spontaneously resolved at 23 weeks, and another case in which also the AP window was diagnosed at 14 weeks that was managed conservatively and resolved spontaneously. So such cases with small AP windows, I feel that few of them could also be false positives, or also the incidence of reporting these cases in the general population is low, and some of them can resolve spontaneously. So my take-home message is that first, AP window is a rare condition with an even rarer antenatal diagnosis. And oftentimes on the three-vessel and the three-vessel trachea view, we feel that there is a connection between the aorta and the pulmonary trunk, but more often than not, this is the right branch of the pulmonary artery, which gives us this false impression. We can avoid these pitfalls by extending our examination and looking at the views, especially with the lateral insonation, the short axis, and the parasternal long axis views. And simple AP window cases have an excellent postnatal prognosis, especially if managed early on. And these babies do very well with almost no need for secondary operations. And finally, I think we need to remember that some of these may actually have a spontaneous resolution. Thank you. And I would like to take this opportunity to thank my mentor Adi sir and Dr. Ashok Khurana sir and everybody here at SFM who gave us this opportunity.
That was an excellent presentation.
Thank you, sir.
Would like to take some questions.
Sure, sir.
Questions you can probably take it later. No?
Later, sir. Okay.
Yeah, maybe later is better.
Yes. So with that, we have a great start to the session with an excellent presentation by Dr. Sana. Now we move on to the next presenter, Dr. Harini. She is talking about an enigmatic Cavum septum pellucidum. Dr. Harini is currently pursuing her fellowship at Adi Advanced Center of Fetal Care in Bangalore. I now request Dr. Harini to please share your slide, please.
Yes, sir. Am I audible, sir?
Yeah, you're audible.
Is my screen visible, sir?
It's visible, yeah.
So good evening, everyone. I'm Dr. Harini Seshadri, and today I'll be discussing about the Cavum septi pellucidum. So we all know that the Cavum septum pellucidum since the 1980s has been considered as a marker of the BPD plane. And over the years, we found that there are several midline anomalies that are associated with abnormal CSP. So we look at a few of them. So first, a little bit on the anatomy. First, we look at the etymology of the Cavum septi pellucidum. So the Cavum word basically means a cavity. The septum basically means lamina or sheets, and pellucidum basically means a clear space. So it's basically a clear closed cavity that is present between the two septi. So the boundaries of the Cavum septum pellucidum include anteriorly it is the genu of the corpus callosum, superiorly it is the body of the corpus callosum, and posteriorly it is the splenium of the corpus callosum. Inferiorly it is bounded by the fornix, and on both sides it is bounded by the septum pellucidum, which are nothing but the laminae or sheets, and they are an integral part of the limbic system. And we all know that it's a sentinel part of midline development. So this is basically a postnatal brain where you can see that there's this thin line here, and these are the two sheets of the septum pellucidum, and as you can see, it basically separates the lateral ventricles from each other. And as we go along, we'll see cases in which the septum pellucidum is absent and the lateral ventricles are fused. So just a magnified view of this where you can see the septum pellucidum, and sometimes some space might be left behind. Usually the septum pellucidum fuses towards later gestation and postnatally, but sometimes a small portion may be left behind, and that is the space that you're able to see. So first, we'll understand that what is the difference between the CSP and fornix, because the fornix is an important pitfall of the cavum septi pellucidi. So suppose I cut the brain at this particular section, you will be able to see the clear cavum septum pellucidum with no midline echo and the length longer than the width. As you can see here, it's an integral part of the anterior complex. But if I take a section slightly inferiorly, you will be able to see a midline hyperechogenic line and two other echoes that are next to each other. So this hypoechoic part is basically the fornices. These two hypoechoic parts are the fornices, and the midline interface is the one that is echogenic. So this is an important pitfall that we beginners need to avoid. So now I just want to take you through this one specimen where again you can see the fornix, which is the white matter tract here, and the midline interface. So this midline interface is the echogenic line that we see in caudal to the cavum septi pellucidi. So the other pitfall that might occur for us beginners is the presence of the third ventricle. So the third ventricle is located slightly posteriorly. What they say is that if you draw a line along the coronal suture, you should be able to see the CSP somewhere anteriorly here. But if you see something posteriorly and it is anechoic, it could be the third ventricle, and that pitfall needs to be avoided. So this is my first case where clearly you can see that there are three lines which are seen, and that is because of the dilated interhemispheric space seen in CACC. Here we can see that the CSP is not very well visualized. So we extended our examination. And here we can also see that there is an anechoic space posteriorly, which could be the high riding third ventricle. And here we are able to see the ventricles dilated. So when we extended our examination, we could see that we could hardly see any corpus callosum in the midline. And that confirmed our diagnosis of agenesis of corpus callosum. When you look at the pericallosal artery, some remnant, the pericallosal artery is seen along some remnant CC which is seen, but it is shorter. So this was a case of agenesis of corpus callosum, and it was also associated with aberrant right subclavian artery arising from the descending aorta. That's what is shown in this stick image, where you can see the aberrant right subclavian from the descending aorta, and this is the rendering of the same. So coming to my second case, intuitively we feel that the CSP appears slightly wider than usual, and we can see that it doesn't look normal. So when we extended our examination, we could see that the CC was appearing slightly thicker and slightly irregular. So this was a case of dysgenesis of corpus callosum. So my third case, here again, when you look at the CSP, I'm not happy with the CSP. It looks slightly small, and we would definitely, 21 weeks would definitely extend our examination looking at the CSP. So when we extended our examination, we could see that the CC was short and short for gestation. So this was also a case of hypoplasia of CC, thinner and shorter. In the same case, we could also see that there was a mediastinal shift to the large congenital diaphragmatic hernia with herniation of the liver as well as the stomach. This is a VCI sweep to show the same, where you can see the left lobe of liver and difference between the echogenicity of the liver and the lung. And this was the upturned SMA sign. This was another case we came across where we could see that the CSP was not well visualized or probably absent. We were not sure. And then when we extended the examination, we could see that there was some remnant corpus callosum tissue anteriorly, but posteriorly we could not visualize anything. The coronal sweep of the same case, we could see some irregularities within the lateral ventricle and a cyst anteriorly. So which is seen in the periventricular region. So these irregularities, if you can appreciate. So this was also a case associated with subependymal nodular heterotopia. Although CSP is not seen at 13 weeks gestation, we can clearly see that there is a communication of the ventricles, lateral ventricles with each other at this early gestation. And in this section, we can see how the orbits are so closely spaced, and there is a midline abnormality in this case. When we extended our examination, we could see the proboscis very clearly. And on 3D also, we were able to visualize the proboscis. This was a case of holoprosencephaly. A-lobar holoprosencephaly. This was a slightly difficult case for us beginners. And here you can see the septum pellucidum is absent and the lateral ventricles are fused with each other across the midline. So as we discussed in the anatomy, when the septum pellucidum is absent, the lateral ventricles get fused. This is to show that the optic chiasma in this case was present. And when we extended our examination, and we also saw that the interhemispheric fissure was very well visualized. So one of the differentials for this is lobar holoprosencephaly, but when the interhemispheric fissure is well visualized, and the anterior CC complex appears normal, it is very unlikely. This is to show that the corpus callosum appeared completely normal. This is the 3D rendering of the optic chiasm, where you can see that this is the decussation of the, this is the decussation width was measured. And we saw that the decussation, measurement was between the 5th and 50th centile, which is normal for gestation. So although the optic chiasm is normal, the SOD cannot be ruled out prenatally, but the risk, but it becomes highly unlikely in the presence of a normal optic chiasm. So this was a companion case to the previous case. In this also we could see the fusion, but then we could also see some remnant septum pellucidum tissue. So this we thought was a case of partial agenesis of septum pellucidum. And at 36 weeks, this case was also associated with polydactyly. This is the coronal 3D sweep, where you can see the fusion of the lateral ventricles across the midline. And at some sections, we're able to see the septum pellucidum. So partial agenesis of septum pellucidum. So this is one case that I want to take and take up to speak to you all about. And here you're able to see that the CSP looks almost normal. But because this case was actually referred to us with FGR, we actually performed the neurosonogram also of this case. But to us, in the screening examination, the CSP appeared normal. When we extended our examination, we could see that for the gestation, the CSP appeared slightly irregular and thicker. So this looked like a case of dysgenesis of corpus callosum, and also the length was falling under the lower centiles. So I took you across. I showed basically two cases. The first case was also a case of dysgenesis, and this 8th case was also a case of dysgenesis, but they had very different CSPs. When you look at the first case, the CSP appeared wider, whereas in the next case, the CSP length to width ratio was almost normal. And this got me thinking, and I did some literature search. So what does the literature say? So this was from the Belgium group, where basically they've studied 86 cases of partial agenesis of corpus callosum, and lo and behold, they found that the length and width ratio was normal in a staggering 50.7% cases. So the length and width ratio more than 1.5 was reported in about 50.7% cases. So are we safe in just looking at the Cavum septi pellucida as a marker of the CSP in the mid-trimester ultrasound is something we need to think about. Also, the gravity of the situation, I would like to explain to all of you, because the severe neurodevelopmental outcome could be seen in even isolated cases of PACC in about 14% of cases, as reported in this 2024 article. This was another study that was done by the Israel group, and they studied CC in all cases. So they picked up 71 cases of PACC over 8 years, and they found that the CSP was normal in about 66%, and those patients, some of them didn't have any indirect signs. So this was the proportion, this was the portion of the population with PACC that we would have missed if we had only looked for the CSP in the mid-trimester ultrasound. So should routine assessment of corpus callosum be included in the mid-trimester ultrasound? I would like all our stalwarts to opine about this. This is just a collation of all my cases. I went through dysgenesis, PACCs, and CACCs, holoprosencephaly, septal agenesis. And my last case, which was a case of dysgenesis of corpus callosum with a normal CSP. So my take-home points for today include that the visualization and evaluation of the CSP and CC needs to be done in always in tandem with the gestational age. And also that CSP could be normal in a lot of, in a good proportion of PACC cases, and that needs to be kept in mind. The pitfalls of the cavum septi pellucida, which includes the fornix and the third ventricle. And also, when we look at the anterior complex and the CSP, we need to see mindfully, magnify and store the image, which is very important. And the last point here is that the CSP always needs to be looked in tandem with the entire anterior complex, including the interhemispheric fissure and the anterior CC. Thank you so much.
That was an excellent presentation, Dr. Harni. You have gone through the entire spectrum of corpus callosal agenesis, dysgenesis, and you raised the right point as to whether we are safe enough to just look at CSP. Of late, I have been seeing corpus callosum in all cases because of this reason. So I'd also like our seniors and stalwarts to comment on this later on. So moving from two excellent presentations, I will now move on to the third presentation by Dr. Pratima Prabhu. She is a consultant in high-risk pregnancy and maternal fetal medicine at Father Muller Medical College, Mangalore. I request Dr. Pratima, who will be presenting on a lung mass, to kindly share your screen.
Good evening, sir. Yes. Yes, sir.
Yeah. So my colleague is working with me in the Department of Fetal Medicine, and she also runs the high-risk obstetric unit, and she'll be presenting a case of cystic lung mass. Go
Thank
ahead.
you, sir. Thank you for the introduction. Moving on to the case of cystic lung mass for the today's evening presentation. This is a case of Mrs. X. She was a 29-year-old gravida 3 para 2 living 2 at gestational age of 22 weeks and 3 days. She came to us for a second opinion in view of an outside done anomaly scan showing a cystic lung lesion. So when we saw her at 22 weeks and 3 days, we saw that there was a single live intrauterine fetus. The fetal growth and liquor appeared adequate for the period of gestation. In the right lung, we could see a cystic lesion. I'll be describing it soon. The heart was mildly shifted to the left. There was no evidence of mediastinal shift, nor was there any evidence of hydrops. So this is the ultrasound image, which is showing a cystic lesion. Here we can see that the lesion is having irregular margins. The septations are seen, but incomplete, and it has a slightly hyperechoic border. This is the 3D rendering of the image showing the right lung involvement. The mediastinal shift is not there, and the diaphragm appears intact. This is a short video which is showing the lesion on the right side of the lung with the slightly irregular margins. And we can also see that there are septations, but they are not complete. In the next video, which is a lateral sweep, we can see the irregular borders with the incomplete septations. Because it was a cystic lung lesion, we have gone ahead and calculated the CPAM volume ratio, and we found it to be 0.5, which is less than 1.6. Actually, less than 1.6 has a good prognosis with the less risk of the fetus going into hydrops, but that is in the absence of a dominant cyst. In our case, this being a completely cystic lesion, we are not sure how the case would proceed, and we thought we'll follow up the patient after 2 weeks. So based on this findings at 22 weeks, we plan that we'll see her in another 2 weeks. If necessary, we'll go ahead with the fetal MRI, and side by side, we will take a pediatric surgery opinion and counseling done by team. So she came back to us at 24 weeks and 3 days, exactly after 2 weeks. This is the image showing the same right lung lesion. And we again calculated the CPAM volume ratio, which is 0.5. This is the image showing the heart, diaphragm, stomach, bladder, and the lesion on the right side. Because we were not exactly sure of the diagnosis because of certain atypical features of this lesion, we went on with ahead with a fetal MRI. And in this fetal MRI, we can see here on the right side, there is a hyperintense cystic lesion with very fine septae. And the diagnosis was query bronchogenic cyst, query macrocystic CPAM. So this was till 24 weeks. We again saw her after another month at 28 weeks and 5 days. Same, the irregular margins persisted. There was septations, which were becoming more clearer with the advancing gestational age, and it was occupying the right lung. There was no mediastinal shift. There was no evidence of hydrops. So this is a 3D rendering of the image at 28 weeks. So this we can see here, it is occupying on the right side, almost occupying whole of the right lung, and the septations are becoming more evident now. So we again calculated the CPAM volume ratio. It was 0.4. Considering it is a good prognosis, but still, because of the presence of dominant cyst, we didn't know exactly how it may proceed. But we have no other option other than the CPAM volume ratio for cystic lung lesion. So we went on ahead with CVR calculation. Meanwhile, we can counsel the patient party, telling them about the findings. We told them that the size was almost similar, with the CPAM volume ratio also being maintained. So because there was no other significant finding like mediastinal shift or fetal hydrops, we planned for expectant management, and the same was discussed with the patient and family. So this is a video at 28 weeks. We can see that the cystic lesion, the septations have become complete. Initially, what we felt were incomplete. Now we can see them complete, and they are looking more towards CPAM. Coming back to the case, we again later saw her only at 40 weeks. In between, she was lost to follow-up, and she came back to us for safe confinement. Considering she had the previous 2 normal vaginal births, we induced her and we delivered a female live term baby, 3.3 kg with good Apgar scores of 8 and 9. Because of the antenatal ultrasound reports, the baby was shifted to NICU for observation. In the NICU, it was seen that the baby was maintaining a saturation of only 91%. It required oxygen support via hood box. So postnatally, again, a CT scan was done. And here we can see that in the right lung, there is a large cyst with septations and measuring up to 64 mm. It was compressing rest of the right lung, and slight mediastinal shift was noted. So on the postnatal day 3, surgery was planned. So this first image is the first 2 lobes of the lung, which is normal. In the second image, we can see the cystic lesion, and these are the cystic lesion which is taken out, and this is the one which is measuring almost up to 64 mm as mentioned in the antenatal ultrasound, the CT scan report. Baby underwent thoracotomy and right lower lobectomy with ICD insertion on postnatal day 3. So this is just an image which I have put into this slide, which shows the antenatal ultrasound 3D, the postnatal CT, and the intraop cystic lesion, which was taken out. So on day 6, the fetal distress settled. It was weaned off ventilator. On day 8, ICD drain was removed. On day 10, the baby was started on direct breastfeeds. And on day 17, the baby was discharged with stable vitals. We also got a histopathology of the cystic lesion, which was taken out done. So these are the low resolution images, which is showing dilated air spaces with complexity of the lining epithelium. And the third image is the high resolution image, which is showing pseudostratified ciliated columnar epithelium hence confirming our diagnosis of CPAM. About the follow-up, the baby is presently 4 months old, doing well, and it is being followed up by the pediatrician and the pediatric surgery team. Coming to the discussion, macrocystic CPAM is quite rare, the incidence being 1 in 10,000 to 30,000. 95% of fetal cystic lung masses detected at screening around 18 to 20 weeks are contributed by macrocystic CPAM. Usually it is unilateral with more than 95% involving one lobe or segment, only 2 to 3% are bilateral. The association with chromosomal and non-chromosomal association is very low. The risk of hydrops is less than 10%. Treatment options where indicated is simple cyst aspiration or thoracoamniotic shunt. Stocker has classified CPAM into 5 types, type 0 to type 4, based on the origin and characteristics of cystic lesion and the level of insult during the embryonic life of fetal lung development. So this is the CPAM volume ratio. Whenever it is less than 1.6, the risk of hydrops is as low as 17%. When there is no dominant cyst, the risk is still lesser, less than 2%. When it is more than 1.6, the risk increases to more than 80%. In our case, we had certain DDs. The first differential diagnosis, what we thought of was CPAM, because here the cyst is either single or multiple and usually unilateral, as in our case. Another DD was a bronchogenic cyst. Here it is a single cyst which is normally centrally placed with no mediastinal compression. The third DD is left CDH. Here there will be presence of bowel in the chest and stomach above the diaphragm. In our case, we could see the diaphragm was intact. And the fourth differential diagnosis is neuroenteric cyst. This cyst is very, very rare. Only 30 plus cases are reported overall in literature, with only 7 being detected prenatally. So this kind of cyst occupies the posterior mediastinal aspect. It is lined by the GI mucosa, that is columnar or cuboidal epithelium, and it is most of the time associated with vertebral anomalies like spina bifida or hemivertebra. And in CPAM, the prognosis depends on the presence or absence of fetal hydrops based on the size of lesion and its secondary effects like mediastinal shift, extent of pulmonary hypoplasia, polyhydramnios, cardiovascular compromise, degree of development of unaffected lung, and presence or absence of other congenital anomalies. In our case, all the prognostic factors being on the positive side, the outcome of both the mother and fetus was good. Thank you.
It was an excellent presentation by Dr. Pratima. So we've gone through first 3 cases. We'll take a short break of 5 minutes. Shall we start? Alok sir?
Yeah, sure. I think you should.
Yes, sir.
You should go.
Yeah. Moving ahead with the next session, our first speaker will be Aditi Jadhav, who is just completed her fellowship in fetal medicine from Karnataka Institute of Fetal Sciences. She is be talking upon prenatal diagnosis of isolated hydrometrocolpos. Dr. Aditi.
Good evening, sir. Can I start screen sharing?
Yeah.
Can you see my screen, sir?
Yeah.
Aditi, can you be a bit louder, please?
Yes, sir.
You need to be a bit louder, Aditi.
Can you hear me, sir?
Yeah.
I would like to hear you louder, Aditi.
Sir,
More louder, yeah.
good evening, everyone. I am Dr. Aditi Jadhav. I have completed my fellowship in fetal medicine under Karnataka Institute of Fetal Sciences at Sri Raksha Ultrasound Scanning Center, Ballari. And today I will be presenting a rather rare case, of which under 30 cases have been reported in literature. So a 28-year-old primigravida came with previously normal NT and anomaly scans, which were done somewhere else, for a growth scan at 36 weeks of gestation. While acquiring axial sweeps through her abdomen, we noticed a well-defined lesion behind the urinary bladder in the midline. It was a cystic lesion with thick internal echoes. There were no septations seen within the lesion, and this lesion was found to be conical or pear shaped, with the narrower end of the lesion extending into the perineum, as you can appreciate here. This was found to be a female fetus, and the cystic lesion showed narrowing or funneling towards the vaginal introitus, as you can appreciate in this still image. Rest of the systems were normal. This was the only positive finding that we noted. So the findings we have are a retrovesical cystic lesion in the midline, which is pear-shaped with no internal septations and showing funneling towards the perineum. So on the basis of these findings, we put down our primary differential to be isolated hydrometrocolpos. This is the postnatal ultrasound of the baby, which showed a similar cystic lesion with thick echogenic content showing funneling towards the perineum, which you can appreciate here. For confirmation of diagnosis, postnatal MRI of the baby was also done. These are coronal and sagittal T2 weighted images, and you can appreciate a well-defined pear-shaped T2 hyperintense cystic lesion showing funneling towards the perineum, extending into the perineum. So clinically, this baby showed a whitish bulging membrane at the vaginal opening, which was the bulging hymen, and an incision was made into the bulging hymen. And as soon as the incision was made, a gush of mucus fluid, thick mucus fluid came out. So this was a case of isolated hydrometrocolpos due to congenital imperforate hymen. Let us go through this pathology in brief. By definition, hydrocolpos is distension of vagina, and hydrometrocolpos is distension of vagina as well as uterus. The incidence of hydrometrocolpos is 1 in 16,000 female births, and it constitutes 15% of abdominal masses in female infants. The incidence of congenital imperforate hymen, which is one of the causes of isolated hydrometrocolpos, is even lesser, 0.014 to 1%, and it is the most common obstructive anomaly of the female reproductive tract. In literature, some familial forms of imperforate hymen have also been reported. The spectrum of isolated hydrometrocolpos can be quite wide, ranging from mild cases which go undetected in prenatal period to severe cases such as ours, where a large abdominopelvic cystic lesion was noted on prenatal ultrasound. Hence, only 22 cases have been reported in the literature till now, and they have been reported as early as 25 weeks of gestation, but most cases, if present, will come to you in the third trimester of pregnancy. In congenital imperforate hymen, you will see a bulging hymenal membrane as such. So the causes of isolated hydrocolpos or hydrometrocolpos can be an imperforate hymen, a transverse vaginal septum, or vaginal atresia. Hydrometrocolpos can either be isolated due to any of these three causes, or it can be secondary to other etiologies, most commonly cloacal malformations. So hydrometrocolpos in general have two types, urinary and secretory type. So as the name suggests, urinary type will have accumulation of urine in the vagina, which is commonly seen in cloacal malformations, and secretory type will have mucoid material accumulated in the vagina due to overproduction by the cervical and uterine glands. So what happens sometimes is there are high levels of circular maternal estrogenic hormones, and this leads to copious amount of secretions by the uterine and cervical glands. When this is combined with any of the etiologies of vaginal obstruction, you get accumulation of these excessive secretions in the vagina. They are trapped in the vagina, causing distension of the vagina with or without the distension of uterus. So commonly, hydrocolpos is more commonly noted than hydrometrocolpos, and this is because the uterus has thick muscular walls which do not distend quite easily. Hence, accumulation of fluid in the uterus may not be detected prenatally. To summarize the findings in hydrometrocolpos, as we saw in our case, you will find a cystic pelvic or abdominopelvic lesion, which will have following features. It will be unilocular without any stations. It will be conical pear-shaped behind the urinary bladder in the midline. It can be anechoic or have low-level internal echoes. Sagittal images, in addition to these findings, you will also see funneling or narrowing of the dilated vagina towards the perineum. So what else do you need to look for? You need to look at the perianal muscular complex. You need to look at the fetal perineum, the urinary tract, the GIT, the lumbosacral region. All of these will be normal in isolated hydrometrocolpos. But if you find abnormality in any of these, you need to steer towards a diagnosis of HMC secondary to cloacal malformations. If you have established a diagnosis of isolated hydrometrocolpos, the next thing you need to do is look for signs of visceral or vascular compression. So if you look at the urinary bladder, you may find it compressed and anteriorly displaced. If you look at the ureters and kidneys, you might find hydronephrosis or hydroureter, and in later stages, acute renal failure or oligohydramnios. If you look at the lungs, you might find pulmonary hypoplasia, which will be secondary to mass effect from a large abdominopelvic cystic lesion. In cases of vascular compression, you might find cardiomegaly, and on MCA Doppler, fetal anemia. You can also go ahead with MRI of the fetus, and this helps us in characterization of pelvic structures and differentiating isolated cases from those secondary to cloacal malformation. On T2 weighted image, as you can see here, you will see hyperintense cystic mass, which is extending into the perineum posterior to the urinary bladder. T2 weighted images will also help you to evaluate the relationship between the genitourinary tract and the GIT. On T1 weighted images, in cases of isolated hydrometrocolpos, you will always see a normal T1 hyperintense meconium filled rectum posterior to the dilated vagina. This will be absent in cases of cloacal malformations. Coming to differential diagnosis of isolated hydrometrocolpos, the most important is cloacal malformation. The primary clue in cloacal malformation is also a cystic abdominopelvic lesion. But cloacal malformations, 80% of them will be associated with duplication of uterus and vagina. So these cysts will typically be septated or bilobed and will be associated with abnormalities of other systems. And on MRI, the normal T1 hyperintense meconium filled rectum that we just saw, it will not be seen. The second DD that you need to think of is ovarian cyst, which will be off midline, higher up in the pelvis, and will not extend into the perineum. This is in contrast to the features of the hydrometrocolpos cyst that we just saw. These are some of the other differentials that you need to think of. Now, the prognosis of isolated hydrometrocolpos is excellent if it is identified and immediately treated in postnatal period. In the neonatal period, the effect of the circulating maternal estrogenic hormones disappears, so the milder cases may resolve in the neonatal period, or they may present in adolescence as hematocolpos or hematometrocolpos. The treatment will depend upon what is the cause of vaginal obstruction, but whatever the modality of repair or treatment, it needs to be immediately drained to prevent sepsis, perforation, or any ongoing urinary obstruction. If you have diagnosed isolated hydrometrocolpos, you need to, at the back of your mind, think of these syndromes and evaluate for them. These are McKusick-Kaufman syndrome, Ellis-Van Creveld syndrome, Bardet-Biedl syndrome, and MRKH syndrome. Now, the 2 points that I want you to take home with you are, if you prenatally diagnose isolated hydrometrocolpos, it will help the fetus to get immediate surgical repair in the neonatal period and help avoid associated complications such as urinary tract injuries or fetal distress. And you also need to differentiate isolated cases from cases secondary to cloacal malformations, because the prognosis, the post-natal surgical repair, and quality of life post-surgery are drastically different for cloacal malformations. At the end of my presentation, I would like to express my humblest gratitude to Dr. Ashok Khurana sir, Dr. Mohit Shah sir, Dr. Adinarayan sir for giving me this opportunity, and my mentors, Dr. Alok sir, Dr. Murlidhar sir, Dr. Raghavendra sir for their support and guidance. Thank you.
That was an excellent presentation, Aditi. You always excelled in your presentations. So moving on from good presentations, we'll now move to our next speaker. Next presentation will be a talk on ventricular megali in third trimester, whether it's stroke or infection, by Dr. Maunika. Dr. Maunika is a fellow who's at KMC Manipal. She's pursuing her fellowship in fetal medicine under Akila ma'am. So she'll be presenting a case on third trimester ventricular megali. Dr. Maunika, carry on.
Good evening, everyone. My topic of today's discussion is ventricular megali. in third trimester. Ventricular megali is one of the most common cerebral finding we see in fetal ultrasound. Ventricular megali is defined as an excess of fluid in lateral ventricles when the diameter of more than 10 mm across the posterior horn of the lateral ventricles from second trimester. We label it as severe ventricular megali when the diameter is more than 15 mm. The term hydrocephalus is used when there is primary or secondary obstruction leading to increase in endoventricular pressure. Some of the causes of obstruction leading to ventricular megali are: primary cause would be aqueductal stenosis, which is the most common cause. Secondary causes being interventricular hemorrhage, infection, infarction, arachnoid cysts, tumors, and masses. Whenever we see ventricular megali in third trimester, it is important to differentiate between primary and secondary etiologies of the cause. Severe ventricular megali, we have to confirm that it is truly ventricular megali and avoid false positive findings. And also we have to do a structural brain evaluation. Looking at the shape, size and contents of the ventricular megali will give us the clue about the etiology of the ventricular megali. So look for the echogenic material inside the ventricles, suggests of hemorrhage. If there is a calcifications in the ventricle or the periventricular zone, suggests more of infection. Also evaluate cortex, corpus callosum, cerebellum to rule out any developmental abnormalities. Check for the midline shifts or any presence of choroid plexus cyst. Also check for the systemic findings. Presence of ascites, hepatomegaly, echogenic bowel suggests more in favor of infection. If there are no systemic signs, it favors into the isolated brain cause, be it intracranial hemorrhage or any structural abnormality. Also, it is important to look for maternal history and laboratory findings of mother. Ask for any history of trauma, coagulopathies and infection, history of any infections. Order for torch serologies, look for any evidence of infections. Consider fetal MRI for a detailed brain anatomy, and do consider genetic testing. Consider amniocentesis if you see any structural anomalies in the fetus. We can consider ordering CMV PCR in amniotic fluid of the baby. The most common differential diagnosis whenever we see third trimester ventricular megali is infection, and second is hemorrhage. So the how to differentiate between fetal intracranial hemorrhage and infection.
Dr. Monica, I can't hear you.
Can you hear, sir?
Now we can.
The differentiating features between fetal intracranial hemorrhage and congenital infections. When shape of the ventricle gives us a clue. Echogenic intraventricular wall, any presence of blood clot, mobile echoes inside the ventricles suggests of intracranial hemorrhage. Clear appearing material suggests of infection. Periventricular zone is usually thickened in cases of infections, and you can see a echogenic mantle which is due to ventriculitis. Brain parenchyma usually is echogenic due to hemorrhage, and you can see cysts in late stages. In case of infections, you can see a cortical malformations, diffuse parenchymal atrophy, cysts or calcifications. Choroid plexus cysts may appear echogenic or clotted in case of hemorrhage. Choroid plexus are usually not involved in infections, or it can be appear calcified. Other brain findings may be there can be a midline shift, hydrocephalus if there is unilateral bleed. Microcephaly and intracranial calcifications and brain cysts can be seen in congenital infections. Systemic findings are usually not present in case of hemorrhage, whereas it is usually present in congenital infection. Additionally, you can see hepatosplenomegaly, ascites, echogenic bowel, and hydrops. Whenever we see a sudden appearance of ventriculomegaly, we should suspect hemorrhage. Whereas there is a progressive ventriculomegaly in case of congenital infections. Some of the clues to differentiate between hemorrhage and infection are: there is sudden severe ventriculomegaly on follow-up scans, which is not present before. There is echogenic material inside the ventricles or in the parenchyma. No systemic involvement. History of trauma coagulopathies is present in favors in case of hemorrhage. Whereas in infection, ventriculomegaly with microcephaly is a classic sign for CMV infection. You can see periventricular calcifications. Maternal serology shows some evidence of infections. Gradings of fetal brain hemorrhage is graded into 4 grades. Grade 1 hemorrhage is confined only to the germinal matrix, which is usually difficult to diagnose on fetal ultrasound. Grade 2 intraventricular hemorrhage without ventricular dilatation, but echogenic material is seen within the lateral ventricles. Grade 3 intraventricular hemorrhage with ventricular dilatation and echogenic clots are visible with progressive ventriculomegaly. Grade 4, the bleed is involving the parenchyma also, often frontal and periventricular zone. Large echogenic areas are seen within the brain tissue. It may also evolve into porencephalic cyst or encephalomalacia. Coming to my case, 34 years, Mrs. X was referred to as at 36 weeks in view of bilateral severe ventriculomegaly. She had a healthy child previously. Present pregnancy was uneventful till now. She had a normal NT scan, normal anomaly scan, and growth scan was normal at 29 weeks. She has screened low risk for aneuploidies. No significant medical or family history. She doesn't give any history of fever or any history suggestive of infection during this pregnancy. These are the prenatal images. First image showing severe ventriculomegaly measuring up to 25 to 31 mm with periventricular thickening. This is the image showing normal posterior cranial fossa with normal fourth ventricle. This is the image showing cystic spaces in the brain parenchyma with echogenic synechiae in the cyst. This is a normal corpus callosum. Third ventricle is dilated with opening of third ventricle recesses. And you can see a porencephalic cyst in the brain parenchyma. The image showing various stages of hemorrhage, old and new, with a synechiae bleed within the cyst. No other ultrasound features suggestive of fetal infection such as hepatomegaly, liver calcifications, echogenic bowel, FGR or placentomegaly. No evidence of fetal anemia. MCA Dopplers are normal. So we gave our differentials as hemorrhage with or without ischemic event or neuro infection. So we have counseled her that exact etiology to be confirmed only after thorough postnatal evaluation using neonatal MRI, neonatal evaluation for toxoplasmosis CMV. Overall, the prognosis is guarded. Baby is likely to have neurological sequel since in literature there is only 5 to 8% of the severe ventriculomegaly will have normal neurodevelopment. However, the prognosis depends upon the etiology rather than the severity of the ventriculomegaly. She delivered she delivered a female baby of 2.9 kgs by elective LSCS in view of large head. Baby cried immediately after birth, established feeding and hemodynamically stable. A thorough evaluation including ultrasound, abdomen, eye, ear evaluation was done. It showed no evidence of intrauterine infection or sequelae. Blood investigations of the baby were reported normal. There is no thrombocytopenia, no leukocytosis, no anemia. This is a postnatal MRI showing the cystic areas in the brain parenchyma with echogenic material within. Multiple cystic area showing with echogenic material within. This is the image showing a old bleed in the germinal matrix and multiple hemosiderin deposits even within the sulcations of the brain parenchyma. So these are the images showing multiple cystic areas again, suggesting maybe a porencephaly due to old parenchymal bleed. So MRI was reported as germinal matrix hemorrhage showing various stages old and new. Intraventricular hemorrhage, old areas of the bleed within the parenchyma is seen as cystic areas, synechiae, hemosiderin deposits in the periventricular zone. MR angiogram is also done. Although grossly all major vessels appeared normal, there were few attenuated branches like right vertebral artery and MCA territory. So ischemia was not completely ruled out in this case. Neonatal workup was done for infection. CMV IgG was high, but IgM is negative. DNA and viral load both are negative. This suggests that acute infection with CMV is less likely in this fetus. Toxoplasmosis also tested negative. We have taken neurosurgery opinion. They have advised if there is increased head size, it requires VP shunt. They have planned for CSF analysis to rule out infection and proceed with VP shunt. Couple requested discharge against advice, refused all the interventions and took the baby home. We collected a telephonic information of this baby yesterday and currently it is doing well and the parents were not very keen on further follow-up. Thank you.
Thank you, Dr. Monica. That was an excellent presentation. We've gone through the entire spectrum of findings of a typical case of a germinal matrix hemorrhage, how it causes ventricular megali and how it mimics infection. So moving to the next presentation, I would like to call upon Dr. Soumya Krishna, who is again a fellow at KMC Manipal. She'll be talking on prenatal diagnosis of isolated growth hormone deficiency and opportunity for early intervention. Dr. Soumya?
Yes, sir. I'm not able to share my screen. Yeah.
Monica,
please.
unshare.
Can you see my screen, sir?
Yeah.
Please go full screen.
Yes. Good evening, everyone. I'm Soumya. Thank you, everyone, my professors and the team from Karnataka chapter for giving me this opportunity to present my case. Today is my topic, prenatal diagnosis of isolated growth hormone deficiency, an opportunity for early intervention. Here, my 27 years old, gravida 2, abortion 1, with short stature, it was referred to us at 16 weeks for a detailed structural survey and further guidance. Both husband and wife are short statured, non-consanguineous couple. No other person in the family was affected similarly. Patient is symmetrically short and completely independent with no fractures or any other symptoms. A fetus was totally growing as a short for gestational age fetus since her early scans, and her NT was normal. And combined screening test also showed low risk for aneuploidy. At 16 weeks, our scan findings were head and AC parameters are on 10th to 20th centile. Symmetrically short long bones were found corresponding to 5th centile. Is it skeletal dysplasia? But we didn't find any features of suggestive of fractures or bowing. Bone mineralization appeared good. No features were suggestive of lethal skeletal dysplasia. No other structural abnormalities were found. At 16 weeks, these are the images of long bones of the fetus. The patient gave the history of being born, self-born with 3 kgs weight to normal parents, was growing normally till 5 to 6 years of age, after which stunted growth occurred. She was suspected to have hormonal deficiency at the age of 12 to 13 years and advised to have growth hormone injections. However, then is it skeletal dysplasia or growth hormone deficiency in the mother? Can growth hormone deficiency in mother affect the fetus? If so, is it hormonal or genetic? So, a medical geneticist opinion was sought. The option of amniocentesis with QFPCR and enhanced trioexome sequencing was discussed with the couple. Fetal growth was monitored meanwhile. The exome sequencing showed a mutation in GHRHR gene with homozygosity and the disease, a growth hormone deficiency, isolated type 4 with autosomal recessive inheritance. A pathogenic variant was found, and this was even found in both parents, the same variant in homozygous state. So, why is this important and how does it impact the fetal growth? Several hormones play crucial role in fetal growth during pregnancy. These include estrogen, progesterone, human placental lactogen, and insulin-like growth factor 1. Estrogen and progesterone are key for overall fetal development, helps develop fetal organs and support the uterus respectively, especially during first and second trimesters. Later on, insulin-like growth factor 1 plays an important role in regulating fetal growth and metabolism, organ development, especially central nervous system, bone formation, and placental function. Other hormones helping in fetal growth include thyroid hormones and glucocorticoids. This contribute to the brain development and maturation of fetal organs. Factors influencing this insulin-like growth factor 1 and thereby affecting fetal growth are basically genetics, nutrient availability, and maternal health. So when genetic mutations in one of these genes, that is GH1 or GHRHR, or other genes involved in pituitary development occurs, it leads to congenital growth hormone deficiency. So pediatric endocrinology opinion was sought, opined that early intervention in the form of recombinant growth hormone supplementation may help this baby in terms of achieving a good height and overall growth to a near normal pattern. Follow-up scans till now are showing good interval growth, overall biometry growing around 10th centile, long bones growing satisfactorily around 5th centile. Currently, she's 36 weeks, mother experiencing some shortness of breath and unable to lie down flat due to space constraints in her abdomen. We may have to deliver her soon by cesarean section. Pregnancy is otherwise completely uneventful. At 31 weeks, last visit, her long bones were growing satisfactorily. So, isolated growth hormone deficiency, what do we know about it? This is a condition where the body doesn't produce enough growth hormone. This deficiency leads to stunted growth in childhood, and the severity of growth failure varies. Its incidence is 1 in 4,000 to 10,000 live births. Only 3 to 30% of cases have genetic origin. So, what are the causes? It can be genetic mutations or idiopathic or other pituitary hormonal deficiencies or pituitary disorders. So, in genetic mutations, these are the 3 genes that can be affected. Growth hormone, growth hormone releasing hormone receptor, and other genes involved. So, what are the types of isolated growth hormone deficiency? There are 4 types. Type 1A, 1B, and 2 are caused due to the mutations in GH1 gene. Previously, type 1B, there were 2 genes, GH1 or GHRHR, which is now called as type 4. And the type 3 is involved with BTK gene mutation. So isolated growth hormone is also deficiency is also called as type 4 dwarfism of sin, or formerly it was 1B. This is a genetic disorder caused by mutation in GHRHR gene characterized this is characterized by early and severe growth failure, presentation with very short stature. They may attain an adult height ranging between 105 and 135 centimeters, which is minus 3.32 between minus 8.6 standard deviation, which is below average. And this is due to a lack of growth hormone. And this variety is not associated with any other pituitary hormone deficiencies or organic lesions. There is the GHRHR gene encodes a receptor for growth hormone releasing hormone. Binding of this hormone to the receptor leads to synthesis and release of growth hormone, whereas mutations in this gene have been associated with the isolated growth hormone deficiency. So what are low on? Insulin like growth factor 1 will be low, and insulin growth factor binding protein 3 concentrations are also low. These patients give good response to growth hormone treatments and a blunter growth hormone response to different provocative tests. Inheritance is autosomal recessive disorder variety, and this is caused by either homozygous or compound heterozygous mutation in the GHRHR gene on chromosome 7p14. What are the features? Proportionate short stature, frontal bossing, and doll feces, hypoplastic nasal bridge, radiologic evidence of delayed bone age, delayed dentition, impaired hair and nail growth, prepubertal symptoms, and high-pitched prepubertal voice are common. Increased abdominal fat accumulation, higher total and low density lipoprotein cholesterol, higher C-reactive protein, except for somewhat delayed onset of puberty, not affecting the fertility, with no signs or symptoms that suggest deficiency of other pituitary hormones. So what can be the treatment for this? The primary treatment of isolated growth hormone deficiency involves recombinant human growth hormone injections to stimulate growth. Treatment is long-term and can be given at home, requiring most often a daily shot post-birth, often lasting for several years. They show a good response without reduced responsiveness over time. The earlier the condition is treated, the better the chance that a child will grow to near normal adult height. It would subsequently enable affected patients to live a confident life and avoid any secondary implications of their disease, such as delayed puberty, infertility, or physical problems. Dosage is 0.18 to 0.3 milligram per kg per week subcutaneously in 6 to 7 divided doses during childhood, and they might require more higher doses during puberty. Prognosis. Isolated growth hormone deficiency 4 has a variable prognosis, but individuals generally experience a normal lifespan and fertility. They may also exhibit some health benefits such as reduced risk in certain cancers and effects of aging. Early diagnosis leads to better outcomes because there will be always early therapeutic intervention. Some cases may have a tendency to develop antibodies to the administered growth hormone, which can make their therapy less effective. Symptoms of decreased muscle tone and decreased bone density leading to osteoporosis may be seen in few cases on long-term duration. So my conclusion, so far in the literature, there have been no cases wherein type 4 isolated growth hormone deficiency has been diagnosed prenatally. Hence, this case highlights the importance of genetic diagnosis when we come across short-statured parents. These cases shows us that prenatal diagnosis opens up the opportunity for early intervention for these conditions, leading to improved postnatal outcomes. Thank you.
That was a very good presentation. You brought in a different aspect of this case. You've already been acclimatized to diagnosing it, skeletal dysplasias, etc., etc. But this altogether different perspective, which actually adds food for thought. Good presentation.
Thank you, sir.
So we would like to take some questions. I would like our mentor Ashok Rana sir, Adi sir, and our national president Mohit sir to have a few comments on the presentations.
I have few, but I will wait for Kurana sir and Mohit sir. Then I'll.
Yeah.
You know, I am just so overwhelmed by the quality of the presentations, by the way they've all been mentored, by the effort that they've put in. And most importantly, that this seems to have emerged as the most favorite learning platform that we've ever had at the Society of Fetal Medicine. We were almost 400 of us at one point.
Yes.
Obviously,
Yes.
then, absolutely brilliant when Varun Thakur came up with this idea and said, let's try the young guns. And Alok said, yes, we'll take it ahead. We'll take it ahead. I wasn't so sure. I thought it would be a nice gaming platform where kids could come have fun. But it's obviously emerged as something that seems to be the best way to learn for all of us. And thank you, Alok, for taking this forward. And thank you, Murli and Dr. Adi today
Welcome.
for presenting such a fantastic set of speakers who've been tutored so well. The depth with which they've done it, the kind of slides they've had, you start wondering whether they are young guns or seasoned speakers. And that's really very nice. They've also displayed an immense sense of keeping their mind open to new ideas and the fact that they need to put this into the perspective of what India needs, and that is a practical perspective. There are situations which are not ideal in terms of what is written in the books or what you hear about in conferences overseas, but things which are peculiar only to India, and that point has also been well brought out. So over to the rest of the team to now carry on this program. Congratulations, everyone.
Thank you, sir. Thank you, sir.
Congratulations, Team Karnataka. It was
Thank you,
wonderful.
sir. Thank-
Now, it is, as he said, not only the depth, it is the choice of cases. Amazing. The way they are presented, the images, the 3D reconstructions, the follow-ups, autopsies, everything was so immaculate. You know, that shows the length to which they are going to get into the final diagnosis and following it up. So I should also, congratulate their mentors for inculcating this discipline into them and it's sort of generating that interest of fetal medicine in them. But all in all, it was a wonderful case discussion. Each case has been unique. Every discussion that they have presented was wonderful, supported by beautiful images. And this has a long way to go. So I'm sure Karnataka has a lot of fetal medicine specialists, and we will see one more young gun webinar coming from you soon. But congratulations to all speakers.
Thank you, sir.
Congratulations, Murli, Dr. Adi, for taking this forward for us. And of course, Varun and Alok have been instrumental at the center level. Thank you to them. I look forward to more.
Thank you, sir. Thank you. Adi, sir.
Okay. First of all, congratulations to all these 6 young guns. What a beautiful presentation. I'm totally mind blown. Everybody stuck to their time, 10 minutes. You know, if you get time, you can explain, you can clear so many doubts. But if you have to present in 10 minutes and to be effective is amazing. And this shows the depth of talent in India. And I'm very happy that Karnataka is shining up now. And sometimes I remember, not sometimes, all the time I remember, I was picked up by Ashok Khurana sir to present in Cardiacon. Although I was not young, but that was an opportunity which shown a different world to me. So you guys are extremely lucky to be guided by the mentors, Ashok Khurana sir, Alok sir, Murli, Mohit sir, and Bimal sir, and so many others. So take opportunity or use this opportunity to present your cases. Today is an example where amazing. The quality of work done is amazing, and I'm really mind blown. Okay, so from the academic perspective, do you want to take questions now or Murali?
So we'll take the
Yes, sir.
questions.
We'll take questions, sir.
Yes.
Okay.
We'll take, yeah.
Uh,
First question, why was red eye not seen in first case? I don't know.
Sana, are you there?
Yes, sir.
So
Excellent.
this is a question asked
just
by
a question.
stalwart. Yes, it is a question asked by a stalwart. So It's a very, very nice question to.
Boss has asked the
Yes,
question.
yes. Boss has asked the question.
Good.
Yes,
Uh,
actually, when we had this case, even my entire confusion was about this, and we had extensive discussions on why it was not. So, I think basically, the thing is that in none of the cases in the Israel paper, they have had an absent ductus arteriosus, whereas in our first case, there was an absent ductus arteriosus. So probably because of that, we are not getting the red eye sign, because in the second case, in our second case also, we are getting the reversal, but probably because of the absent ductus, we have not gotten the reversal.
Not probably. It is because of that. Because
Yes, it is because of that. Yes.
the blood is not going into ductus arteriosus. The blood with a higher pressure is pumping the blood into aorta. So if you see in normally if there is a ductus arteriosus, the pressure difference is little bit less in the pulmonary. So that's why the blood comes from the aorta to the pulmonary. Here, there was no ductus arteriosus. There was no way the blood can escape to anywhere other than going to the aorta. So that's why the red eye was not seen. So, Sana, it's a lie. You said we extensive. We knew that is because of that only. So we didn't have much difficulty.
Yes, sir. On my part, there was.
Because there's a tiny flow reversal which happens provided ductus is present. That is what is seen as red eye. Here, when ductus is not present, you're not going to see that segment getting imaged, and that flow reversal is not there. That's why it's not.
Yeah. So we got to be careful about red eye.
Yes.
I know.
Yes, that is there.
Since time immemorial, we have saw this one, but we did not name it as red eye sign until somebody named it beautifully. The question is, we need to be aware about our PRFs, and we need to see there are a lot of false positives and false positives will be there. So you got to be careful, and you need to make sure that you are seeing the red eye, and it is not the right pulmonary artery going underneath. So you got to be careful. I mean, I had not diagnosed AP window after coming back to India. I was so worried. I was thinking, have I missed money? I'm sure I've not missed. It would have come back to me. So I had a lot of false positive diagnosis because I wanted to diagnose one AP window. Until this last year, I had 2 cases. I had not seen AP window in India. So we got to be careful. There are a lot of false positives will be there. So Sana rightly showed the right pulmonary artery. You need to establish.
That's very important.
Separately when you see a red eye or when you make a diagnosis of AP window.
Partial volume of right pulmonary artery mimics AP window. That is why she has clearly shown that both are at different level.
Yeah, and you have
That
to
is
insert
important.
it laterally to see the defect. Otherwise,
defect.
it is not. We have lot of false positives. Sana would have shown a few cases. A lot of false positives will be there.
Yeah, so for AP window, at least you need to examine from multiple angles.
Multiple angles, yes.
It's not easy.
Yeah.
The best will be the lateral.
Yes, best will be the.
Yeah. What size of aortopulmonary window connection is important?
Sir, in all the literature that I've read, they've not actually mentioned that size is important. What they have said instead is that whether it is a simple AP window or there is any associated abnormality, for example, an interrupted aortic arch, which will change the prognosis.
Yes.
Sana, what is the detection rate? Did you find in
Yes, sir.
What is the detection rate?
So they have said 0.2 to 0.6%.
My God, 0.2 to 0.6%.
0.6%.
My unbelievable. Okay. Good. Go on.
Many a times red eye sign seen how to confirm antenatally. That's
Yes,
what sir just told, huh? Yeah.
Yes, again, that only that we have to see from multiple views. We had shown in our case the parasternal long axis, the short axis views, and the lateral insonation. So those are very important so that we are not misdiagnosing the AP window.
Plus the PRF is important.
Yes, PRF also, if we are getting it
PRF
only in
is
one
important.
artery, only in the pulmonary, for example, not in the aorta, that may be more significant. If it is a very low PRF, then again, we may be getting turbulence.
Getting a lot of, yes.
Sana, in that stick volume, where
Yes.
the stick was acquired at the level of on-force view of the AV valve.
Yes, sir.
That was a beautiful angle to demonstrate the AP window.
Yes, sir.
Yeah.
Yes.
On-force view, of the AV valves, and then you will see the branches beautifully.
Yeah. Dr. Harini, what was the diagnosis or DD for case number 6? Case number 6 was the last case, Dr. Harini? Was
No,
it the last?
8 cases.
9 cases were there too. 8 and 1 companions. 1 second.
Meanwhile, any other comments?
Yes, sir, we had diagnosed that case actually as septal agenesis because the optic decussation width is normal.
Show the case.
Yes, sir, 1 second.
Okay. Meanwhile, anybody else, any other questions we can answer?
So one more question is how to, prognosticate when you have septal agenesis, but the optic tracts are normal.
Yeah.
We could combine both of them, I think. 6th one is septal agenesis only, no ma?
Yes, sir.
Yeah. Okay. Beautiful case. All right. This was what was the gestation?
So the gestation was about 21 weeks.
Okay. So we got so beautiful images. 21 weeks. Okay. Fine. What was the question? What was the diagnosis? Was the question.
What was the diagnosis? Then how to manage case
So
of
this was a case of isolated septal agenesis,
Yeah.
sir, because the optic chiasma was normal, although we cannot completely rule out septo-optic dysplasia prenatally. The risk is about 19% if there is septal agenesis, but the risk almost becomes halved if the optic chiasma is seen nicely. So we had given both differentials, but we sadly don't have follow-up of this case. Yes, sir.
If you are given an option to do further test, what test would you do to say it is SOD?
So fetal blood sampling can be done to look for estriol levels. Even
Before
maternal
fetal blood sampling, can you do maternal blood?
Yes, sir, we
maternal,
can.
maternal.
Yes, sir, maternal blood sampling also can be
Or-
done for estriol levels.
Yeah.
Then there are some emerging genes also which are implicated for SOD, sir, like HS6 gene, then SOX gene also has been implicated. But that's all mostly it requires validation, and some of the genes have been implicated, but we don't know what percentage of SODs will have those genes and what percentage will not have. So to clear cut differentiate whether it was septal agenesis or SOD, probably genetics will not help.
Yeah, good. And also it's evolving. We don't know yet all the genes yet.
Yes, sir. Also, one more aspect I would like to bring out here is that, like pituitary, if you don't do the maternal sampling, or even if you do the maternal sampling, the pituitary hormonal levels could be normal prenatally, as in the pituitary could be normal prenatally, and postnatally at 4 or 5 years also they can manifest with abnormalities like fetal adrenal insufficiency. So, clear cut, we cannot say prenatally if it is septal agenesis or SOD, but we can definitely make a calculated guess.
Yeah, but in future, maybe we can do MRI with tractography.
Yes, sir. Some articles
But
of that.
even then, we may not win because we may, even though the tracks are there, it may not be working. So it is very difficult to predict. And in our ecosystem, and if you look at the literatures, 25% of the fetuses who deemed to be isolated would have SOD after birth. So that's a significant number. 1 in 4 isolated, so-called isolated SOD, septal agenesis or SODs. And SOD is such a nasty disorder. I mean, I had seen only one case in UK, and the patient used to come, the pediatric population has to come every week, and that baby, the girl, had all kinds of endocrinal abnormalities. This is heartening to see that morbidity. So that's why it is very, very difficult to reassure our population. Whatever you did, even if you did I don't know whether anybody does the fetal blood sampling to look at the hormones, but even if you did it, it's very difficult to reassure our people. That's my take.
Also, one more thing, sir, growth hormone deficiency is the most common one in SOD. Although we look at ACTH byproducts, growth hormone deficiency is the most common.
It's a spectrum and depends on what was abnormal. Not all will be abnormal, but when it all abnormal, it's very difficult. I agree. The growth hormone is the easiest, the commonest one. But if you do it only ACTH related estriol, we will fail. So that's why these are all corroborative evidences. There is not a single patient we can confidently say that it is SOD. Of course, if the optic tracts are very small or extremely smaller, you would judge more towards SOD. If it appears normal, can I put my hand on my heart and say this is an purely isolated? It's very difficult.
Yes. Thank you, sir.
Is there a possibility of CPAM showing resolution in later pregnancy?
This was
Dr. Pratima. I'll take that. Yeah. Yeah, there are many cases where we have seen CPAM getting resolved as pregnancy advances. One close thing is we have to have one more diagnosis of congenital lobar fluid overload as a differential diagnosis, because compared to CPAM, this resolves. So what we have done, we do an MR at maybe at 30 weeks. So that on a fluid overload, you have something called stretched vessel sign. The hilar vessels are stretched, go up right to subpleural area. That is fluid overload. Unlike in CPAM, where the hilar vessels are distorted and interrupted. So that gives us a push to counsel the patient as to which line we are going. So in most of the cases, we have in the last 1.5 years, we have around 12 cases of CPAMs. All are managed till birth. No terminations. So in that, we have 2 cases of fluid overloads, others were CPAM. Eventually, a paper does say that 43% of cases diagnosed as CPAM turn out to be fluid overloads, which go on resolving as pregnancy advances. So you need to have a close watch on, especially on the microcystic CPAM cases, right? So yes, they do resolve, especially up to 28 weeks. They grow in size. From 28 weeks, they start resolving.
Yeah.
Microcystic ones, yeah. No dominant cyst, no other findings, etc.
Can I make a point?
Yes.
They do disappear, but they appear to disappear because the lung echogenicity becomes brighter as the gestation advances. So the differentiating the mass to the normal lung parenchyma can be very difficult. So they appear that they disappeared, but they're still
Yes.
there. And it may not be shown in X-rays because after birth, if they take an X-ray and they say unnecessarily they worried us, there was no lesion. So that's what you need to, I mean, I'm sure pediatricians are educated. If it need be, you need to mention that it may not be, or you need to communicate with them that you need to do either a CT or an MR to get more information rather than just a X-ray. But most of them are asymptomatic.
Yes.
They may not want to do any investigation. If they become symptomatic, they do investigation. So certainly about
Yes,
30% is a literature. Now 40% is a good thing. 40% will resolve.
and it is the microcystic one that we see they seem to resolve. It's not the macrocystic one. They
Micro
persist.
ones.
So Murali, was there a histology done in your case?
Yes, sir.
Yes.
I mean, that case, only one case underwent surgery.
On that case, because I wanted to know.
Yeah. Our case, which we presented, sir, histology was done. Histology was done.
And
It
also
had,
one more. Yeah.
Yes. That macrocystic one.
Good. And if you look at all the histology data, around 84% of the CPAMs are actually hybrid lesions.
Yes, correct. That is there.
Yeah.
And regarding, yes, how to assess for pulmonary hypoplasia in CPAM or other cases, is there any formula? Actually, we go with, whenever we have a CPAM, we go with a CPAM volume ratio. But of late, what I have seen in case of diaphragmatic hernias, what we are trying out is diffusion imaging and ADC mapping of the lungs. That has proven to be more accurate than your CPAM volume ratio. We are trying it out, and we will bring out more data on that. There are specific patterns for normal lung and affected lung.
Please
So
enlighten, please enlighten.
So actually, we do a diffusion, we do MR, sir. We do diffusion MRI and ADC mapping, like how we do on brain. So that we do it for the lungs. So based on the ADC values, we calculate how is the how good or bad will be this lung as the pregnancy advances. That we have just started, sir. We are in this trial process.
Okay.
So will be coming out in another 1 year's time about whether it's good for CVR ratio or whether it's better than CVR ratio, or it's almost the same.
Great, great,
Right now, we are doing CVR ratio, but we are parallelly working on that.
great.
Yes.
So the opposite lung, it matters a lot in
Yes.
diaphragmatic hernias.
Yes. The affected lung, remaining part of the affected lung, because what happens in ultrasound, we don't get to see how much of lung is seen behind the lesion.
Right.
But on MR, we can see what is the portion of the lung which is seen behind the lesion. So we can calculate the volume, MR volumetry, and also do the ADC mapping. So that we are working on that. It's just begun with that application specialist. We'll come out with that.
Fortunately, most of the CPAMs are innocent.
Innocent, yes, they are resolving. This will help in diaphragmatic hernia, sir.
Diaphragmatic hernia is still make a sense.
Yes. This is for Adi, sir. What is the indication to intervene in CPAM antenatally? Shunts.
Why me? I've never intervened for any CPAMs yet. I'm still waiting.
If it's a huge cyst, sir, if it's a big cyst, macrocystic, large cyst.
So
Causing a lot of mediastinal shift or hydrops.
A lot of mediastinal shift.
Word of advice. I'm growing gray hair, so I can start giving advices. Masterly inactivity, watchful expectancy becomes a norm as you mature and as you start looking at failures. So avoid putting a needle wherever you want. When you're young,
yes,
the cystic space, you want to put a needle because that's how all of us enthusiastic, exciting young people will do it. But as you grow, as you mature, as you see the world, you know, watchful expectancy,
yes,
masterly inactivity is required.
Inactivity.
Yes.
Very good.
CPAMs,
Very good point, sir.
CPAMs, rarely they require. If they are more than 1.6, and if it is a macrocystic, where the good thing with a macrocystic, multiple macrocystics, they are all connected. So if you put a needle into one,
yes,
and aspirate, the whole cystic spaces will be evacuated. So there is a good chance of resolving by putting a needle. But don't put a needle until it is causing too much of a damage, like massive mediastinal shift, more than 1.6 CVR, high drops. Then you put a needle. Otherwise, no.
Yes.
Most of the time, they are very
I
soft.
did recently one hydropic fetus with a sequestration. I lost the baby as soon as I finished my procedure. The radio frequency, I ablated. Interstitial laser I did, ablated the vessel, and I was thinking I did a fantastic job. 2 minutes later, the baby died. So, I mean, of course, it's a desperate case and it was dying anyway. But you need to understand, and if you lose babies, it will teach you more and more. So avoid putting a needle as much as possible. And only if it is absolutely necessary, yes, you can do it.
Even
Putting
in this
stents
case,
is
sir,
almost out of the question. Draining, most of the time, it helps in CPAM. If reaccumulates, you can put a shunt also. So that's one of the few places where you still do shunts.
Even in this case, sir, the pediatric surgeon advised not to intervene antenatally. And what turned out to be, it's a cyst in the lower lobe. So
Because they're losing a baby, losing a patient.
So what they did, they resected the lower lobe. And they say even we have cases where they've resected 2 lobes and babies are doing well.
Yeah.
So resecting one lower lobe will not cause much of a problem. So at the end, they resected that lobe and baby is doing well.
Good.
And one more point, in case of diaphragmatic hernias, what they say is even if it has a bad score, what more can happen is once it's born, if it survives the surgery for first 4 weeks, if it survives, it goes on. Then there is no looking back. It's not like some bladder reconstruction or a temporary colostomy where they have to come for resurgeries, etc. So they say, let's give a chance if the parents do want to. We had one case with bad scores. It had developed Klebsiella pneumonia post-surgery, but it pulled through and baby is now 1 year old. So we had never had this thing that baby is going to pull through.
No, you got That's anecdotal. You got to understand there are long-term lung diseases or more
Diseases, yeah.
common. So it is not always easier, especially if your LHRs is too bad, not always easier. You got to understand one case pulling through encourages it, but it is associated with long-term problems also.
Yes.
Next
How to counsel the parents regarding hydrometrocolpos as PAC PNDT is strict?
Ashok sir probably
Ashok
will.
sir. Ashok
whack
sir
you
will
on
tell.
it.
Purana sir will
This is
answer.
The PCPNDT is not that it's strict. The law is the law. The law says that wherever it is relevant, you do a sex determination. The tragedy is that the interpretation of the law is done by people who are not bothered about the female fetus or female feticide. They are the ones who bothered about having power. And
Yeah.
that is the tragedy of the bureaucracy.
I
It has
totally
nothing to do with the law.
Yeah.
Law clearly says that you do a sex determination before you do a CVS for a carrier state for DMD. So the law is very nicely in place. The misinterpretation, and in Delhi, we're very lucky. We don't have such problems. But I know many districts all over the
In
country.
Delhi, you are there, sir. That's why.
Yes, but well, there is this power game where
Yeah.
all they want to do is show that they are superior as human beings compared to you, and that so-called feudalism that I am a bureaucrat, I am superior. Very sad indeed, but that is the reality that we have to learn to accept. But truly speaking, there are so many situations where automatically the patient would look up a word, especially with ChatGPT, and they would come to know what the sex of the baby is. In fact, you can now put an image into ChatGPT and says, what's the likely diagnosis? The paid ChatGPT. So I don't think there'll be an end to this in terms of an argument, but the fact is that in an appropriate situation, you have to let them know the sex, and it is perfectly legal.
Okay.
In any case, these cases they present in the third trimester, so
True. Yeah.
Yeah.
so
Correct.
it is easier.
The last two questions are on cyst aspiration, which sir has already dealt in detail. Why cyst aspiration was not done, preventing lung hypoplasia and all that. So Adi sir has spoken about answered both the questions in detail.
I think we are done with the questions.
Done with the questions.
And there was a request to show those positive cases, for Dr. Sana to show the AP window images.
Yeah,
false
that's a
positive
beautiful
ones.
one, ma'am.
Yes.
Dr. Ima Bindu came to us for a autopsy workshop.
Yeah.
Amazing case. What a beautiful dissection she does. Unbelievable. Shoma, Sana.
Yes, sir. Sir, the false positives.
No. The autopsy
Autopsy.
picture.
Autopsy. Yes,
Yeah,
sir.
in that the coronary ostium can be
Yes, sir.
mistaken for AP window.
Yes.
And also
Yes.
that one. It's beautiful
Yes.
dissection. And that fetus had a retroaortic course of brachiocephalic vein. And,
You had this couple of 1 year back also, you had one case, no, sir? Retroaortic course of BCV.
Second case. Yeah.
Second case, yeah.
That was an isolated one.
Yeah.
I mean, it's a little mental. In our protocol, we see the brachiocephalic vein in all fetuses. So that's why we pick up isolated useless. No significance.
This
All right.
was the one.
You have that video now. You
Yes,
without
sir. Yes, sir. I have the video, sir.
amazing one.
So this one, sir.
Play the video first.
Yes, sir. So this we are going in to see, sir. This we had seen the right-sided aortic arch.
Yeah.
And we were trying to look for the retroaortic left brachiocephalic vein. But again, the tissue was very friable. So when we were dissecting, actually, we've cut through one of the branches of the aorta, but we can see behind over there only.
Correct.
That is the retroaortic left brachiocephalic. It was collapsed, but quite nicely seen. And we've seen here, sir, through the left ventricle. This is the AP window.
Show this one. No,
Yes,
no,
sir.
keep.
Yes, I have the images for that one, sir. I'll show. I'll zoom in and show. So this is the one, sir, left ventricle outflow tract, and this was actually the sinus of Valsalva.
Suppose if we dissected, we would have thought that as a AP window. Of course, we should have looked at the coronary ostium also, but we are not day in and out, we dissect them. So because of Imabindu madam, the enlightenment was easier.
Yes, sir, definitely. She was amazing throughout the autopsy. And also, actually, we would have actually thought that that is the AP window and said type 1 because in a lot of the type 1 AP windows, the coronary is actually coming from the pulmonary instead of the aorta.
Correct.
So that is an associated defect. So that is why we could have easily thought that that is the AP window and not that. But because we're seeing the sinus of Valsalva here, and clearly we can see the coronary artery ostium. And
Yeah,
then
now,
that's why we said that
one
that
second,
is.
sir, 1 second. If you close that the cusp now, it
Yes, sir.
completely blocks, overlaps on the coronary ostium. Amazing. So this,
Yes.
the idea of anatomy, we can utilize in the ultrasound when you have a defect. Upstream, the
Yes, sir.
aortic valve, then it is a coronary ostium. If it is a downstream, it may be the perimembranous VSD. So
EST.
doing an autopsy, amazing. So it enriches your ultrasound. Go
Yes,
on,
sir,
ma'am.
definitely. So this was the AP window, and then because of the distance between the coronary ostium and the AP window, we have said that this is type 2. As in, anyway, on ultrasound also we had thought that this was type 2, but then reinforced by autopsy.
Yeah, we reported as type 2, not with the greatest knowledge, because it was little bit too far.
Yes,
That's why
sir.
we said it's type 2. Okay, go on.
So that is the AP window. And here nicely we can see this is the sinus of Valsalva, this is the coronary artery ostium, and this is the AP window.
Lovely.
It's very easy to mistake the coronary ostia for the AP window.
Absolutely, absolutely. Fantastic.
Good.
Anna, did you show any false positive cases? Because Dr. Omkar wants to see.
Yeah, we had, I recorded yesterday one case for false positive. Did you take that case, ma,
So
from?
I actually have two cases. One earlier also we had recorded.
Excellent. Good, go on, go on.
I can show them. I have. They're not very well curated, sir, but I can show them.
I was feeling sad that you don't have that cases. Amazing. You're an amazing girl.
Yes, sir, I have the. So this was one case, sir, in which here
Look at
also
that,
we
look
had
at
thought
that,
that there could be
Look
a
at that.
small defect.
Stop.
Sorry.
Yeah, stop there. Yeah, drag it. Stop there. Look, this looks like a AP window. So that is
Yes.
actually the beginning of the right pulmonary artery. Play that one. Play that.
Correct.
Play that.
So now actually we're able to see, sir, that that is the branch, pulmonary
Absolutely.
artery,
Yeah,
and there was no defect.
absolutely. Beautiful.
So this was one case, sir, and I have one more.
Excellent. Go on, ma. Good girl.
In this also, sir, quite nicely we can see
Beautiful.
just.
Mind blowing. Yes. So when you rotated the probe and you
Yes,
do
sir.
a lateral insunation, this was the first case, first clip. No doubt it was a AP window in an untrained eyes.
Yes, sir. And then when we went in to examine further, actually, we saw.
That is the view.
So now we'll see, sir, that this is actually over here. If we see it is going beyond, it is not the defect. This one is a little bit better clip.
Yeah. Slow it down or pause it and drag it is much
Yes.
better. It's irritating.
Over here we can see, sir, actually this
Yeah.
is one branch and that is the other. So there was no defect. It was just the right pulmonary that is going underneath it that sometimes it gives.
Look at that. Come back to the apical insunation. Yeah. If you keep there,
Yes, sir.
AP window without,
You can see the defect.
that is actually the right pulmonary artery, beginning of the right pulmonary artery. When you drag it, drag a little bit.
Yes, sir.
Drag a little bit. Look, drag.
Now
There
we
you go. That is a right artery. So you should be extremely careful. I was thinking I had not diagnosed AAP window for a lot of time. And all my fellows who after finishing training, they started diagnosing AP windows. I was a little bit depressed. So I was looking for AP windows for long. Only 2 cases I had in the last year. Okay, go on. Lovely. Beautiful case, ma. I didn't think that you took those cases. Impressed.
So I thought if we have time, we can show. So
Excellent. I'm impressed. This is what a sign of a star, budding star.
thank you, sir.
Ashok Sur,
The last question.
Face.
I'm very impressed yes.
Amazing. Good.
So
Okay.
the last
I
question,
have
sir.
I have one question for Harini though. Harini,
Yes, sir.
so now the Israelian or a Belgian, which is that paper, where 11 cases out of 71 cases had a normal CSP in
Yes,
a PA.
First paper.
that was the second paper actually, sir. The Israeli
Israelian.
group that was, sir.
So in Israel, the protocol is to take the CC in all cases. Am I right?
So in that particular study, it was a retrospective review, and they've clearly mentioned that they've seen the CC in all the cases, sir. And
So
then
they
out of all the
actually
cases, they got 71 cases, sir.
no, they actually look and document the CC in a sagittal section in all cases.
Yes, sir. In that particular article, they mentioned that they have looked at the CC in all the cases, and in fact, even in the centers that are referring to them, they are looking at the CC and
Absolutely.
referring to them as query PACC, and then they're looking at it in more detail.
So now the question is, how strongly we can ignore the sagittal section of CC when you have a normal looking CSP?
In my limited understanding of whatever we have seen, I feel that we should look at the CC in all mid-trimester ultrasounds. Especially
Excellent.
after 21 weeks, we should be looking because there is a lot of emerging evidence about CSP being normal. In spite
Correct.
of everything, initially we looked at only the CSP, then we looked at the length-width ratio, then we looked at Z-scores of length-width ratio. In spite of that, we are not faring well. So,
You know, the reason why we are not, we assume the CSP normal shape has got a normal CC because many of the partial agenesis of corpus callosum may not be symptomatic for a few years.
yes.
And only about 17, 18% or maybe 20% of isolated PACs are symptomatic in terms of neurodevelopmental outcome. So 80% of them, you don't even know that they have got a partial agenesis of corpus callosum at all.
Yes, sir.
So the moral of the story is, even if CSP looks normal, you cannot reassure yourself that corpus callosum is normal. So you need to actively look for it. In terms of advising to a general fetal medicine or obstetric ultrasound, it may not be appropriate because you cannot do CC for everybody. But in terms of tertiary care, or if there is any abnormality in one system, then you need to document. That's what in our protocol is. We look for a CC in all cases, especially if there is one abnormality in anywhere, even if it is a SUA, even if it is a EIF. So we have a CC in our image library. And getting a CC in a sagittal section can be a little bit difficult, and it may not be possible in all cases. But if you are getting a BPD, all you need to do is to take a quick 3D sweep, even at a mid 1, mid 2, or a low quality sweep, and rotate the volume to get a sagittal section. So I always keep telling everyone, it should take only 9 seconds to get your CC, 3 seconds to take the sweep, 6 seconds to rotate the volume. So if you have a BPD, if you can get a BPD, appropriate BPD, CC is easy. Just get one sweep, and you should all have a 3D machine. If you don't have a 3D machine, then you're not doing a fetal medicine work. It's not a fetal medicine work. That's what.
So one more interesting thing in that particular article was I wanted to see if there is any correlation between normal CSP and which part of CC was abnormal.
Correct.
Is it possible that when the splenium is abnormal or when the body is abnormal, the CSP might be normal? That also they have studied. In that article, they have said that there is no particular correlation with which part of the CC might be abnormal. But if there is single segment involvement, it is more likely the CSP can be normal in comparison to multiple segment involvement.
Of course.
So
Good.
that
I mean,
was,
if it looks grossly abnormal, then it's easy peasy. But when it looks normal, that is where the problem.
yes. Thank you.
Yes. Well, good.
So you may want to include the posterior complex also in your protocol, but posterior complex can be little bit irritating. You're not going to get always, but the splenium is the one which usually miss. If you are not in the habit of doing a sagittal section of a brain in all cases, at least anterior complex and posterior complex, if you see, that is a better compromise.
I think the pattern recognition of the posterior complex need to sit in the head so that we'll be able to see it in.
Yeah, we're doing the profile, we look for the nasal bone, right? So that is where that time only I try to finish off looking for the CC. I look for CC. That is where we can train ourselves to look in the CC in that section also.
Yes, sir. Thanks.
So I think we are done with cases. So questions rather.
One more question is there, what you said.
No, I think
No, sir.
no, it's all done.
It's done, sir. Done.
Amazing.
We still have close to 200 people listening to our discuss.
Thoroughly thrilled.
200 people attending the discussions. That is amazing.
Amazing.
Not
Yeah.
just waiting till the last question to be answered. Amazing discussion. Wonderful job, Team Karnataka.
Thank you, sir.
Let's have more of young guns.
Yeah.
Yes, sir.
Thank you.
Thank
Badhiya.
you, sir. Thank you.
Sir.
Good night, everyone.
Good night.
Bye-bye.
Good night. Good night, everyone.
Good night. Good night.
Good night.
Good night.